Well, welcome everybody. I'm Don Berwick. I'm chair of the Committee on Accelerating Progress in Traumatic Brain Injury Research and Care, and it's a privilege to lead this amazing group. I'm very pleased to be joined by fellow members of the study committee. We are examining the landscape of TBI care and research, and we will be producing a report that identifies major gaps and challenges in care and research, that highlights opportunities to accelerate progress and provides a roadmap for advancing TBI research and clinical care. This webinar today is an open, on-the-record information gathering session. The committee is in the process of assembling information for the study. And during this session, members of the committee may ask some probing questions. And I'd like to advise you, these may not always reflect their personal views. I want to emphasize the committee has made no conclusions or recommendations yet, and we're going to be deliberating thoroughly before we write our draft report. That draft report is going to go through a rigorous review by experts who are anonymous to the committee, and the committee will carefully respond to these review comments before the report's finalized and released. Right now, we're expecting the committee's report to be publicly released early in 2022. It's now my great pleasure to turn the lead over to committee member Dr. Jennifer Bogner. She's director of the Division of Rehabilitation Psychology and vice chair for research and academic affairs at the Wexner Medical Center at Ohio State University. Jenny, it's all yours.
I'm not able to start my video. It says that the host has stopped it. Now I can. Okay, great. Well, thanks, Don. Thanks, Don. I'm very happy today to welcome my colleagues from the TBI model systems to talk about the gaps and challenges that we face in terms of caring for persons with prolonged disorders of consciousness. These three individuals have led the charge in terms of starting to address those gaps. And I think they can provide us with some great insight today. So let me go ahead and introduce them and give the floor over to them. We have Dr. Joe Giacino. He's a professor of physical medicine and rehabilitation at Harvard Medical School and the director of rehabilitation neuropsychology, the disorders of consciousness, and the neurorehabilitation laboratory at Spaulding Rehabilitation Hospital. He led the multidisciplinary expert panel that developed the diagnostic criteria for the minimally conscious state in 2002, and the 2018 practice guideline update on disorders of consciousness, co-sponsored by the American Academy of Neurology and the American Congress of Rehabilitation Medicine, and the National Institute on Disability, Independent Living, and Rehabilitation Research. I'm also going to introduce Dr. Risa Nakasi-Richardson. She's a professor and research director in the Department of Internal Medicine, Sleep and Pulmonary Division at the University of South Florida, and clinical research director and neuropsychologist at the James A. Haley Veterans Hospital in Tampa, Florida. She serves as the co-chair of the DOC Special Interest Group in the National Institute of Disability, Independent Living, and Rehabilitation Research, TBI Model Systems, and the Disorders of Consciousness Task Force within the Brain Injury Interdisciplinary Special Interest Group of the American Congress of Rehabilitation Medicine. And finally, Dr. White is a physiatrist and experimental psychologist. He's the founding director of the Moss Rehabilitation Research Institute, where he continues as a scientist emeritus. His research career has focused on the cognitive sequelae of traumatic brain injury, with a particular emphasis on disorders of consciousness. He co-led with Dr. Giacino the multi-center trial that led to the treatment guidelines supporting amantadine treatment. He was elected to the National Academy of Medicine in 2015. Joe, go ahead, carry on. Thank you.
Thank you, Jenny. And my thanks to the committee for giving us this wonderful opportunity. Look forward to the discussion period that will follow. So Bridget, can you bring up the slides? Great, thank you. And we can go right on to the next slide. So this is our game plan. I'm going to start us off and I'm going to review the current state of the science in disorders of consciousness, and then talk a little bit about some future directions. Risa will follow, and she will address unmet clinical needs in this population and the implications they have for health service delivery. And then John will wrap up discussing challenges related to our current system of care in the US, and he'll present an alternative model that has previously been discussed. Next slide. I don't see the next slide yet. There we go. Great, thank you. So what do we know about diagnosis in disorders of consciousness? Well, for starters, approximately 4 out of 10 patients who are believed to be unconscious actually retain conscious awareness when they are reevaluated using a validated standardized assessment instrument. We know that the greatest threat to accurate diagnosis is the one-off bedside examination. This is a complicated condition that is challenging because there are many confounding factors. A single exam is associated with 36% misdiagnosis rate. If you do 5 examinations on that same patient, you can get the error rate down to 5%. Many people are not aware of the importance of serial examination. We also know that a diagnosis of minimally conscious state versus vegetative state, and sometimes that distinction is difficult to home in on, within the first 30 days of injury is associated with a much more favorable outcome at 12 months. So it's really important to get the diagnosis right for prognostic purposes. Next slide, please. So how can we improve diagnostic accuracy? Well, we now have updated evidence-based practice guidelines. As of 2018, they were released. And this was a major effort that was co-sponsored by the American Academy of Neurology, the American Congress of Rehabilitation Medicine, and the National Institute on Disability, Independent Living, and Rehabilitation Research. This is a great start because the new guidelines provide much more specific guidance on diagnostic assessment, including some level B recommendations. So a level B recommendation means you should consider doing this because there's an adequate base of evidence behind it. Prior version, published 25 years ago, was far less detailed and did not have the same base of evidence, not surprisingly. So these are the, I won't go over these now, but here are the 5 recommendations, sorry, 6, 1, 2, 3, 4, 5, 6 recommendations that pertain to diagnosis. The problem is that we need to translate these into clinical practice. There are some significant points of departure between these guidelines and others that have been released by some other societies. That has to be reconciled. We have to employ translational strategies that will be informed by implementation science to identify barriers and facilitators to promote utilization of these guidelines. And Risa is going to talk some more about that in her talk. Next slide, please. Turning to prognosis, we know that early prognostication at the single case level, the person level, is very imprecise. The confidence limits around individual predictors are very wide, and many acute care providers are not aware of the available data on long-term functional outcome after prolonged disorders of consciousness. To highlight this point, I've juxtaposed some data on withdrawal of life-sustaining treatment extracted by the American College of Surgeons TQIP database. That's the table on the left by Teresa Williamson and her group at Duke, against the chart on the right, which is some data from the TBI Model Systems program. And I want to just take a minute to break this down. The table on the left is a bit hard to read, but basically it indicates that life-sustaining treatment was withdrawn in 26% of patients with TBI in this large database. So 37,000 people, about 7,800 or so had life-sustaining treatment withdrawn. And then the jump out point is the median time to withdrawal of life-sustaining treatment was 3 days from onset in this group with TBI. I think this is concerning for 2 reasons. One, we just discussed the fact that early predictors are imprecise, but we're making a very grave decision within 72 hours of injury. And the second point is that patients with severe traumatic brain injury frequently don't show signs of emerging consciousness until 4 to 8 weeks in many instances post-injury. So that's clearly past the point of the ICU or the trauma center. The graph on the right shows data from the TBI model systems. So these are patients who were not following commands when they were admitted to inpatient rehab. So we can infer they were not following commands and had disorders of consciousness during the ICU period, but they regained ability to follow commands prior to discharge. On the x-axis here are items from the functional independence measure. So these are fairly high-level behaviors like walking independently, doing stairs, bathing, dressing, feeding independently. And then on the y-axis, it's the percentage of patients who were independent in those behaviors. The 4 lines indicate the percentage of individuals who regained independent functioning along the dimension of those behaviors on the bottom. So the bottom line in the light blue indicates that at the time of discharge, between 10 and 20% of this group had regained independence in these behaviors. But look what happens over the course of the first 1, 2, and then 5 years later. We're talking about 60, 80% of survivors regain functional independence in these behaviors, but it doesn't happen till much later. So we have to keep this in mind when we're doing early prognostication. These 2 side-by-side charts, I think, really highlight the disconnect that we have. Next slide, please. How can we improve diagnostic accuracy? I think the committee has previously heard testimony from others prior to our group about the importance of predictive biomarkers. So it's every bit true here as well. I think we can turn the corner by using the promising evidence that's coming through that functional neuroimaging, functional EEG, and blood-based biomarkers like GFAP, UCHL1, tau, and NFL light all may play a role here in improving prognostic accuracy when they're employed in the acute period. So I think we have reason for optimism. Next slide, please. What do we know about treatment? So let's start out with, I think, this head-spinning fact. Fewer than 1 in 5 persons who survive moderate to severe TBI receive any inpatient rehabilitation. Where do they go? As best we can tell, they go home or they go to long-term care facilities right out of the trauma center or the ICU in many instances, or the ward. That is further complicated by the fact that we have no effective treatments in the acute recovery phase, and only a single treatment that's been proven effective to accelerate the pace of recovery in the post-acute phase, and that's the drug amantadine hydrochloride. But even here, we don't know the optimal treatment window for use of this drug. We don't really know the optimal dose. We do know that there's an effective dose, but we don't know that it's been optimized. And we definitely don't know what the responder characteristics are for this population. So a lot of work left to be done here. John, I think, will come back to this top issue about the problems we have with people not even getting into inpatient rehab and sort of falling off the map early. How can we improve treatment effectiveness? I think to change the landscape, clinical trials as well as observational studies need to better address center-specific differences. We often don't account for these in our studies. The massive patient heterogeneity needs to be dealt with. We need to use sample enrichment strategies to minimize the effects of heterogeneity. We have to deal with spontaneous recovery. We still don't have a handle on that. And we know that the spontaneous recovery that occurs in this group is actually quite significant. So a treatment has a pretty high bar to get over to show that it's going to work above and beyond what spontaneous recovery is doing. And we also have limitations in the outcome metrics that we're using. I won't go into those here. Many people are familiar with that. So we need to validate biomarkers and improve our outcome metrics from where we stand right now. And we certainly have to conduct more long-term outcome studies, and get the word out that these patients often change for a much longer period of time than we previously thought. Next slide. So I'm going to just wrap up by bringing to the committee's attention this recent series of articles that appeared in the American Journal of Bioethics Neuroscience that looked at resource allocation for patients with disorders of consciousness. I'm sorry, I should have asked to advance this slide. My apologies, Bridget. Oh, I didn't realize there was animation. You can keep going all the way through. Sorry about that. Keep going. So these are the two of the papers. This is the Target article on the left by Andrew Peterson. And then there are 8 commentaries in this series that was just published in the American Journal of Bioethics that all comment on the Target article. So I'd like the committee to be aware of this because I think it some really thoughtful conversation in this series. I'm going to turn it over now. We can go to the next slide to Risa, who's going to pick up on unmet needs in this population. Risa?
Hi, everyone. So I want to transition to talking about the patient experience and following inpatient rehabilitation. And what I have here are data from, again, the TBI model systems, which has allowed us to publish information about those who come to rehabilitation not following commands. So on the left, I'm trying to emphasize that these are very medically complex patients that require access to specialists to manage not only immediately after brain injury, but even beyond that. What I have depicted on the right is a table from one of our papers back in 2013 comparing rehospitalization in the first year following traumatic brain injury. And what we see is that compared to individuals with moderate TBI, severe TBI, those with a disorder of consciousness have a higher rate of rehospitalization, 2 times that of those with lesser injury severity. And we see that the reasons for rehospitalization are different than those with lesser injury severity. It's very challenging to see, but denoted on the far right are some symbols indicating if that the DOC group had higher rates of inpatient rehabilitation hospitalization following their initial stay, higher rates of rehospitalization for seizure disorders, for other non-seizure disorders, but neurologically related, infectious hospitalization. So again, a group that continues to require access to specialty care beyond their inpatient rehabilitation stay. Also in 2013, we looked at the mortality rate of this population in the TBI model system data set, and we noted that those with DOC, again, denoted by that status of not being able to follow commands at the time of inpatient rehabilitation admission, had a reduced life expectancy of about 12.6, which was double that of those with other levels of injury severity in the model system database. Other papers that have come out, both in 2013 as part of a special issue spotlighting this population, and more recently as part of a congressionally mandated report on the chronic effects of TBI. Comorbidity burden is common in this patient population in the first 5 years after brain injury. And not only that, but the burden and individual health conditions were associated with multiple outcomes across the ICDH2 domains. Next slide, please. One of the unique elements of the congressional report that was just submitted this past week was that we were able to highlight some of the rehabilitation needs in chronic stages. So I've highlighted one of the manuscripts from the report that talked about rehabilitation needs at 5 years post-injury. And I sort of condensed lots of pieces of information in this slide. First, there are a lot of needs at 5 years post-injury across injury severity groups. And many of those needs remain unmet. And so you see in the table on the left, the different kind of rehabilitation needs that people told us about. On average, people had 8 rehabilitation needs at 5 years post-injury, which wouldn't be surprising because individuals with DOC improve over time and they develop new needs, things that we didn't target when they couldn't do things earlier in rehabilitation, or perhaps they experienced a decline and need additional resources. And so what you'll see on the right-hand side of that table are the proportion of individuals reporting having an unmet need across those domains. And on average, it was just under 4 at 5 years post-injury. Across the board, all severity groups wanting more help with their cognitive health by endorsing improving memory was the most common need and unmet need, including those for DOC. But what I highlighted in the red arrows are where the DOC group, the severe TBI group, had disproportionately higher unmet needs. And that was in the area of solving problems, help with coordinating services for their medical care, improving their vocational skills or finding employment, being able to engage in recreational activities, coordinating rehabilitation services, finding opportunities to socialize, and just getting around their community. In fact, what you'll see on the far right-hand side, one of the best predictors in that manuscript that we highlighted of who was going to have unmet needs was a measure called the CHIEF that evaluated environmental barriers to having your needs met. And what I highlighted for you here are the type of environmental barriers that individuals endorse commonly with unmet needs. Next slide. So how do we go forward from here, especially in the chronic stages of TBI? When asked to prepare for this talk, people were asking for our suggestions for low-hanging fruit. So some of the things that we think are really important in advancing TBI research across the injury severity groups, but particularly with this patient group, is really engaging stakeholders in the research process. One, we would like to see the TBI funding mechanisms that are available allow for more innovation from the field. Many of them today are very narrowly focused, prohibiting our ability to advance research, particularly with this patient group. We would also like to see the kind of mechanisms available to the field shift to include things like engagement mechanisms. Right now, stakeholder engagement is being talked about in some mechanisms that TBI researchers are pursuing, but not all. And many of the stakeholder engagement activities that are part of the peer review process are tokenistic in nature and not really engaging stakeholders in a way that's influencing and directing the topics that we're studying, how we're studying them, the outcomes that we're using, and how do we get that information disseminated to all relevant stakeholders. A discussion point that we've talked about at length in many of the forums that I'm in today are really trying to understand what outcome is the most important to the patient and family. And that's particularly true with this patient group, not only from a clinical perspective, but also a research perspective. And my last point on this slide is that we'd really like to see more ways for various groups to collaborate together. Not only professional organizations who are working in this space, but also the types of scientists that are working in this area. Right now, scientists that do clinical research versus health services research versus implementation research go to different conferences and have different conversations that don't really help us advance translation in some of the key areas that we've talked about today. And I'm sure the committee has probably heard about some of the other initiatives that are going on with this patient group, particularly the Curing Coma campaign, and what a missed opportunity that we don't have more opportunities to engage these organizations together to move the needle for severe TBI. Next slide. So additional clinical and research recommendations. We want to see more work to inform precision medicine interventions, improve prognostication relative to patient-centered, patient-chosen outcomes. Other areas of research include the development and refinement of treatment targets and options and models of care, specifically case management. And with this population, which I think was really highlighted in the unmet rehabilitation needs slide, we need models of care that are friendly to persons with disability. We have a lot of policies that address how a person in a wheelchair gets into a building, but how they navigate the healthcare environment or their community in general is still very prohibitive to persons who are dependent and rely on others or who are just generally in a wheelchair. And then lastly, we also need age-appropriate long-term care models, especially for our younger individuals with disability. And I put here a quote from one of our mixed method studies about ongoing rehabilitation needs. And here aging parents are describing that they weren't anticipating spending their retirement years taking care of their son, and they have a difficult time even leaving their home because the community doesn't really accommodate them. Next slide. And this is a slide loaned to us from the Curing Coma campaign. I think the committee has heard some of these topics in prior testimony, that some ways to move forward from a research standpoint are to look at a tiered approach to care. Future work can include evaluation of EMR data and discharge outcomes to evaluate models of care and how patients fare with those different models of care. And sort of the next tier, or the next level of research could involve prospective cohort studies that have outcomes, and there could be basic and advanced sites that do basic elements, and in some sites and more advanced elements, perhaps with advanced biomarker evaluation to examine their value and long-term outcome. And in parallel, embedded in those sites would be just comprehensive follow-up over the lifetime to understand the long-term trajectory of this patient population, spontaneous recovery and decline, and within that network embed clinical trials at all stages of recovery. Next slide. Lastly, I want to just highlight the importance of the need for us to implement the evidence that we've created. The communities that all of us represent on the call today have worked for a long time to get evidence synthesized on disorders of consciousness. So getting the guideline that was published in 2018 implemented into practice, and the minimal competency recommendations for the provision of rehabilitation for this patient group promoted and implemented in practice is needed. And what I have sort of denoted on this figure is a schematic of a framework for accessing healthcare. And we know from our stakeholder meetings for disseminating these products and in the creation of these products that there are barriers to care on the supply side as well as the demand side for our patients to receive evidence-based care. And so with that, I will turn it over to Dr. White.
Thanks, Risa. I'm aware that we're really at time, and so I'll try to be very brief. I really wanted to emphasize what I think we would argue is one of the largest gaps that is sort of a meta gap that affects a lot of the issues we've just talked about. Can we go back to the slides for a second?
John, I think we're okay. I know what your slides look like. I think
okay.
We have time.
Okay. So it's been mentioned early on that the current system of care doesn't allow most patients with disorders of consciousness to enter rehabilitation. And Dr. Giacino mentioned that about 20% at max of severe patients with severe TBI do end up in inpatient rehabilitation. We believe it's even smaller than that for patients with disorders of consciousness. Are we able to get to my slides, which were right after Risa's?
It's slide 16, if that helps.
I'll try to talk from memory. Okay, there we go. All right. So the way the system works in the United States right now is that such patients receive everything when they're in intensive care, whether it's traumatic or non-traumatic, they're receiving typically high intensity care. But as soon as they're medically stable enough not to need that level of care, they are discharged to one of the following locations: acute rehab, subacute rehab, skilled nursing facilities, or home. But it's important to remember that of all of those, only acute inpatient rehab has really any research infrastructure. And so it's tough to do research once patients are discharged to any of the other locations. And currently, most insurers, in order to authorize inpatient rehabilitation, require clear evidence of emerging consciousness and some evidence of improvement. And as Dr. Giacino has already told us, few acute care providers are able to marshal that evidence. Next, please. So this is not an evidence-based system. Think about it. The time that a patient is ready to be discharged from acute care is variable and arbitrary according to when they're medically stable. So ironically, a patient who's medically less complex could miss the opportunity of rehabilitation because on the day they're ready to leave acute care, they don't happen yet to be conscious. So if at that moment in time, the patient's not conscious, they may be referred to a nursing home or to a family home and never reevaluated after that for rehabilitation admission. Yet we know that many patients who are unconscious at that time period still have a high chance of meaningful recovery. We know that patients at that level typically have a lot of medical comorbidity that's not well managed in a nursing home. We know that we relatively rarely see patients referred upstream to rehabilitation after they've been discharged to nursing homes or to family homes. And we also know that no one is able to talk to them, their families, about prognosis in the timeframes where prognosis can be accurately estimated. So whatever they heard in the first 3 days, that's the last they ever got talked to about prognosis. And we also know, of course, recently that there's a lot of evidence that multidisciplinary intensive rehabilitation is important for their recovery. So we have everything telling us that the system that is predominant in the United States is counter to the evidence in multiple dimensions. And we're denying meaningful rehabilitation services to a large number of people. Next. So what does that result? On a clinical side, it results in suboptimal functional outcomes because we're not catching people as they begin to recover and optimizing that. We can't revisit prognosis with caregivers as it becomes more defined. So it's likely that patients are bouncing back and forth into acute care because family members are still hopeful about prognosis that has now perhaps become much more bleak, but there's no one available to rediscuss it. There's likely increased costs from repeated readmissions for medical complications because we have evidence that early intensive rehabilitation can help manage and control those medical complications. And as Risa mentioned, we have evidence of increased mortality. But there's a catch-22. Few intensive rehab programs are well positioned to provide care for patients with disorders of consciousness. Why? Because they're not allowed to admit such patients and therefore they can't develop clinical expertise in caring for them. Now, on the research side, patients discharged to nursing facilities and home, as I mentioned, are disconnected from the research infrastructure. And there are financial disincentives for any given nursing home in concentrating disorders of consciousness patients in a way that might be clinically optimal, giving them more experience, because these are expensive patients to take care of. And so it's not a good idea from a business model to have a whole bunch of them under one roof. So you can't admit who you can't study, and you can't study who you can't admit. And this prevents us from having any kind of coherent understanding of long-term implications of our system of care. Next slide. Now, there is an alternative model, which a number of us advocated some years ago and which exists in a number of places in the world. And that's to refer all patients with disorders of consciousness after acute stabilization to an intensive multidisciplinary rehab program where they receive expert evaluation and prognostic assessment. That's not forever. That's for a time-limited evaluation and management period. And it sorts those patients into those who are making rapid gains and can be referred to intensive functionally oriented rehab programs, to those who are making slow gains and can be referred to subacute programs that provide more slow stream rehabilitation over longer intervals. And for those not showing recovery at all, to nursing facilities or homes, but now with a link to a knowledgeable center, with a link to a data collection follow-up system, and with the opportunity to request consultations from the expert facility when things change. And in all cases, with the option to move upstream if the clinical condition warrants it. Well, who provides a system like that now? It sounds kind of Pollyanna-ish. Well, the Veterans Administration more or less provides it. Workers' compensation insurers more or less provide it. And several Western European countries with universal healthcare systems provide it. Is it perhaps not a coincidence that those entities that are on the hook for a lifetime of costs recognize that an early investment in stabilization and rehabilitation pays dividends? And I'll stop there.
Thank you, Joe, John, and Risa. This was great. An excellent overview of some of the issues that we're facing. In the interest of time, I'm going to be asking you guys each one question, and it's the same question, and that way it'll allow our other committee members to ask questions as well. Each of you have talked about very substantial changes that you think need to happen. They all sound, many of them sound to me like they're very important, but also very difficult to reach. What would be some low-hanging fruit, or where should we start? What would be the best start for us to get to some of the goals that you addressed today? And Joe, why don't you start?
Sure. So, Risa made reference to the campaign to cure coma. Just a little bit of background for those not familiar with it. This was an initiative started by the Neurocritical Care Society and now has some backing from NIH. And one of the major problems that we've had that by all accounts has slowed us down is the siloed approach, right? So we have the acute care side and we have the post-acute care side, and they don't talk, or they haven't. So this campaign really is making a concerted effort to change up the way we do business. So I think the first order of business is to have an infrastructure that really interleaves the acute and the post-acute sides, both in terms of clinical and research activities. And I think the approach that the Curing Coma campaign has taken is the right one. So it has a series of modules. Some are research-based, some are clinically based, mixed with mixed representation from the acute and the post-acute side in all areas. So we've already got, I think a lot of headway made because there are a number of white papers that have been written up now. We have a roadmap that's been charted. So for me, this is the right start. We need to get some investment into that. Right now, it's there's no money behind that. We need to get grant funding to support that, and maybe some additional RFAs that can help it along the way. But I think that's, to my mind, where we should go.
Thanks, Joe. Risa, what would you say?
I thought about that question before I developed my slides. And so I would, go back to my stakeholder engagement slide. I think we have work to do there to understand the outcomes that are important to patients and families. A bulk of the work we've done to date have been the outcomes that we think are important, and, developing models that are important to us, measuring things that we think are important, but we really don't know what is the outcome that patients and families want, and and how that might change. So I would advocate that slide really represents my thinking on low-hanging fruit.
And John?
Well, I'm not sure that I want to advocate low-hanging fruit as opposed to very important high-hanging fruit that will be as valuable as a number of low-hanging fruit. So, I agree that we can learn a lot, and we have learned a lot by cobbling together data systems in the current healthcare environment. But I think that there's so many things that are less efficient and that we can't fix even when we have the data coming in to tell us how we should fix them, unless we're able to manipulate the healthcare delivery system at the same time. So I've been seeing for my whole career the ways in which the design of the healthcare delivery system has prevented the delivery of evidence-based care to this patient population. And I guess I would like to advocate specifically for demonstration projects that combine support from CMS or the healthcare delivery side with high caliber research funding, so that we can really see what the impact of more model systems of care could be on the outcomes that we can study right now, but that we can't actually affect very well.
I knew you would come up with an alternative idea. Okay, thanks you guys. That was very helpful. And I know I can catch you later to follow up on some of those things. I want to give other folks a chance. It looks like Dr. Schreiber, do you want to go ahead and ask your question?
Thank you. Very nice talks. I'm a trauma surgeon. I take these patients, end up on my service during the acute care period. Joe showed us beautiful data that improvement is happening years later. John mentioned that once they leave the acute care, it's hard to get them into rehab. So I think the dilemma here is that there's a brief period of time for which rehab is paid for. And we want to get the patient into rehab when they have the opportunity to maximally benefit, which frequently is not at the end of the acute care stay. It may be later. How do we optimize the timing of this brief period of inpatient rehab, and how do we deal with the patient once they've been discharged to get them into rehab?
Maybe I can start on that one. You raise a really important issue, and something that we on the rehab side talk about is when is it best to use those limited resources that many patients have. And just first of all, I would advocate a rehab payment system that allowed the distribution of those resources over a longer period of time. I think that the front-loaded model, again, doesn't match the evidence that recovery can happen over prolonged periods, and that people may need tune-ups and re-interventions as their functional level changes. So we do need to be able to distribute that money. But there's a problematic reality right now, which is that family members are desperate to get into rehab. There's other rehab hospitals that are willing to take the patients into rehab. So our experience at my hospital is when we say, you might better save those resources for a few months down the line and sit it out at a nursing home temporarily, is they go to another rehab provider who has less expertise than we do and still use their resources. But the other thing is that I think that we don't know empirically that that's even the best thing to do, because some of what we do, of course, in rehab is engage the patient volitionally in various kinds of learning-based activities, and that's best done when they are higher level. But a lot of things we do are manage really serious medical comorbidities and functional problems that will go downhill in a nursing home if they're not managed up front. So I think it's actually an open question whether it is necessarily wasteful to allocate a bunch of resources early, even when patients are minimally conscious, because I think we're allocating them to solve a bunch of other problems. But it's a good topic for study.
I would just quickly add that, you know, there is benefit to doing careful monitoring in that early period. You learn a lot more information that I think is very relevant to downstream treatment needs, prognosis, if you do careful monitoring, systematic monitoring. The problem is that payers outright say, we don't pay for assessment. So, you know, that you know, has never stopped ringing in my ear, that line, which just blows me away. But you know, that is the current system. You know, this idea that you have to, first of all, be able to show that you can participate actively in your rehab in order to be authorized to get rehab. Where else in medicine does that exist? It's crazy, but that's how the authorization guidelines work for rehab right now. Families and patients are locked out for that reason very often.
And I have had occasions where I tried to bring a patient in from a nursing home some months later, where the payer said, we don't have evidence that that rehabilitation in the chronic phase is valid. So, you know, you kind of can't win.
And I would just add that the last position statement that we published really redefined what rehabilitation is for this patient group. And it defies what people conventionally think of as just rehabilitation of active participation. So that's one of the things that we really want to see implemented for this group.
Thanks, Risa. Don, do you have a question?
Yes, I do. Actually, two quick ones. Dr. White, you mentioned some other countries that have more developed models. Question is, you know, which are they, and are they documented? And Joe, I believe you said, Dr. Giussino, something about a roadmap. I hope we have access to that.
In the one that I know the best is Denmark, where there are 2 neurotrauma centers in Eastern and Western Denmark, and everybody with a severe brain injury after acute care is referred to whichever one is closest. And then from there, they get referred downstream to various kinds of lesser community services and so on in the chronic phase. And they have an annual check-in follow-up regardless of where the patients go and so on.
We're looking for models, so if that's documented, you make sure our staff get that.
Yeah, I can just say that what I was referring to, again, comes out of the Campaign to Cure Coma. And I think that all the materials that were presented are freely accessible on the NIH website, or I can try to corral them and get them to the committee if that's easier.
I've sent them on to a few folks, and we can, I think that Katie can make sure that everybody has it on the committee.
Yeah, I think there are both, the white papers are available as well as the slide decks that go beyond, in some cases, beyond the white paper.
Oh, I don't have those. Corinne?
Hi, thank you. So I'm an epidemiologist in public health. I think a lot about health and systems of care outside of the healthcare system. So thinking 5 years out and such long recovery, it probably still continues. Is there any answer about what kinds of systems, schools, workplaces, families, where some of this care can be integrated? Just because the relative cost of healthcare seems to be high. I live in Iowa, which is rural, so it's awful hard sometimes to get to outpatient care. So is that an area where we have some answers?
Well, I mean, I don't know that we have answers. I certainly agree with you that the vast majority of care can be delivered out of the hospital in the post-acute period. It's mostly around functional needs and behavioral issues and so on. But, you know, assuming adequate early stabilization, it doesn't tend to be so heavily medical after a certain point. I know the challenge, I think the challenge in community-based, you know, is we're not going to have a DOC specialized community program in every community. So the question is how to design probably programs that are more around functional needs and are adequately knowledgeable about a range of etiologies to work effectively with the different etiologies. But, you know, we have tended to certainly be kind of disease focused and diagnostically focused, which then as you get out into the post-acute and more rural areas makes it harder and harder to sustain. So I don't know that I have a brilliant answer to that part.
You know, one thing that I think can be considered, it requires an initial investment, but then, you know, probably pays for itself down the line is a care navigator, you know, a model. This has worked for other complex medical conditions very well, both from a economic standpoint as well as an outcome standpoint. The thing about this though is, and, you know, we've pursued this a bit, is that you can't, you do have to have specialized training for the navigators. We tried to incorporate this into our own system, which is well established with care navigators for other conditions like you know, cardiology, diabetes management. And they simply said that, you know, the complexity here is beyond what we can do. So you have to have a plan for training the navigators. But once that system is in place, and it's not really ever been tested for brain injury, but, you know, by all accounts, you know, people say it's perfect for that sort of a management system.
And just to go back to the Danish model, because I think it's probably relevant in this case too, is that, you know, individuals with DOC who sufficiently recover go back to the community. They go to community-based rehab services that also receive people who have developmental disabilities and other sort of comparable limitations. And I would say my colleagues who work in TBI, one of their criticisms is that they don't feel that there's enough specialized expertise about the particular cognitive and behavioral needs of individuals with traumatic brain injury in those mixed settings. So that's the trade-off.
Risa, were you about to say something?
I was just going to add that in general, case management following rehabilitation is not covered by insurance. So this is an area that's very challenging for patients and families, especially in those chronic stages at 5 years out.
Yeah. I've been told we can go a couple minutes over if we need to. So just to let folks know that. Jeff, Dr. Manley?
Yes. Hi, gang. I just wanted to maybe ask John to delve in a little bit deeper into the barriers. I mean, I think a lot of us know this, but who are working on the front lines of trying to get people from acute care into rehab. And in particular, one of the things that we find on the acute side is this 3-hour rule that you have to be able to participate for 3 hours. And so I'd like for you just to comment on that and you know, for us to be able to capture potentially for the report where we see the barriers, because they're vast and there are many, but if you could just comment on the 3-hour rule and some other barriers that you see to getting folks into rehab.
Well, yeah, Jeff is referring to this rule that in order to be considered appropriate for payment for inpatient rehab, you're supposed to be able to tolerate 3 hours of skilled therapy per day, PT, OT, and speech in some combination. And again, that was based on this notion that we've referred to repeatedly, that rehab has been defined as a thing where the person has to be an active learning participant in order for it to be worth doing. And that certainly is the common model throughout much of rehabilitation. But we do a lot of things that aren't that don't require active participation and are still valuable for this patient population. You know, my experience, but I don't say this too loudly, is that we keep the patients busy with 3 hours of those disciplines doing productive things, and that seems to meet the criteria of a 3-hour rule. So they don't necessarily scrutinize how much did I do with the patient during that hour and how much did the patient do with me in that hour, although they can. So that's certainly one barrier. I think the bigger barrier is many insurers have a review up front and they won't consider that patient appropriate for admission at all. Others will admit them and say they need to be making very rapid changes, and they'll review every week. And if they don't meet a certain amount of change in the coming week, then they'll need to shift. I'll mention one other reality constraint that is a very big one, really, and that is the effect of social support. So because the hospital is ultimately on the hook for the resources, right? The insurer doesn't say we will pay until you can find a good place to send this patient. They say we will pay until day after tomorrow. It's up to you to find a good place to send this patient. What that means necessarily is that hospitals try not to take patients that they won't be able to find a good place to send, because they will be left holding the financial bag. So that means if you don't have enough money for a nursing home, I need to know that your family can do it, and so on and so forth. And that means then that people whose families can't do it don't get accepted. And so there's big resource and family support filters that deny patients access because it's so costly to the facility if they can't discharge the patient in the end.
Yeah, and I would just say that one comment that was made too, and I think by you, John, is that the current practice is not matching up with the emerging evidence. The emerging evidence suggests that we've got this just absolutely backwards. So one, we're letting people die that don't even have a potential to get rehab. Now we don't even, if you're at a place that allows you to live, then you can't even get into the rehabilitation. And then they front load this in a way to where, that's not where you need it. You need it trickled out. So there's all kinds of things, in my opinion, that are wrong with the system. And I appreciate your time today and really educating us about this.
Right. I'll just mention before we leave that topic that that many insurance plans provide something like 60 days of outpatient care after your discharge from inpatient rehab, and then you're done. So again, the notion is you'll have a brief inpatient stay, you'll have some outpatient tune-up, and then you're good to go for the rest of your life. And alas, that is not the way it works.
Yes.
Dr. McCrae, Michael.
Thanks, Jenny. I've got a very specific question. First of all, thank all three of you for doing this. It was really informative, as we knew it would be from you. Joe, you mentioned that the stat that less than 20% of these patients go to any form of rehab. What might be helpful to our committee and a real sort of hammer in our report, are any of you aware of an apples to apples comparator statistic, for instance, in stroke, that would really make this story even more compelling, to suggest that because I think it's a combination of lore and frankly bias in the TBI space that has that number so low, and I'm guessing it's much higher in, for instance, stroke.
I don't know, Mike, the answer to that. I've not seen, I certainly haven't seen any comparisons that have been published. I said less than 20%. The number is actually closer to 15%, in fact, when you look at the data, which comes from a couple different places. So yeah, I don't know if there's been a direct comparison.
I don't know either.
We could dig around for that. But.
Yeah, I think there actually has been, and I put in the chat a a study done, I believe it was in Denmark, but I put the citation in there that showed early continuous rehabilitation was associated with improved neurologic recovery and lower cost compared to people who were discontinuously hospitalized, meaning there was a gap between acute care and rehabilitation. And I believe there was a recent meta-analysis looking at cost effectiveness across various health conditions, and there were mixed findings. Some diagnoses showed a cost benefit, whereas others did not. Stroke, I believe they did find that early rehabilitation was associated with better cost effectiveness.
So I don't see that citation. Did you?
I put it in the chat.
Yeah,
it's in my slides in the comments as well.
Thanks, Teresa. I'm going to pick that up on that. Okay, I think that we have gotten through all of our questions. I want to thank you guys again for taking the time out to speak with us today. I think we've gotten a lot of valuable pearls to take in and think through for our report. So thank you again, and thank you to the committee for sitting in, and y'all take care now.
Thanks. Bye-bye.
Bye-bye.